We talk about it in two different contexts. One, it's within the tumor mass itself, and the niche can really just be a physical location that can be defined by the stem cell and then the immediate cells surrounding it in the tumor, and the signals that are communicating back and forth to regulate that stem cell, to either tell it to divide or not to divide. And we've been able to model this in a petri dish and been able to identify the particular characteristics of the cancer cells that surround the stem cell and how they interact. But what we've also been able to determine is that there's a second niche, and that is when you get away from the primary bulk of the tissue and you get to areas where the cancer cell is in direct communication with normal cells of the body, normal cells of the bone, normal cells of the lung. And in that case, the stem cell is communicating with these normal cells in a different way that it communicates with its cancer cells, but that's also a niche. And I think we don't have the data yet on this, but I think what's at least we know initially is that those signals are not the same, and that for whatever reason, when those cancer stem cells are in contact with these normal cells, they do behave differently than when they're in contact with cancer cells. And I think that might speak to the fact that they might not divide as quickly, they might not be as sensitive to chemotherapy or radiation, and which will allow them to be more dormant, so that maybe in 10, 20 years they could come up again and grow out again. But this is still ongoing work that we really don't have all the data yet for.
But it gives a hint for why prolonged therapy may be important, because of the history of the way these cells can develop really over time in terms of their relationship with their environment, and this dormancy concept and this kind of awakening from dormancy that we're trying to avoid. And of course, obviously, as has been pointed out so well, we have to balance the benefits we get from prolonged therapy against any side effects that may occur with these medications. So it's going to require laboratory science, it's going to require clinical science to take those laboratory scientific ideas and then translate them. And in BCRF, we're trying to do both and trying more and more to relate them.